Okay, well, good morning and welcome to the GAP MASLD MASH Community Network. My name is Lindsay Pratt and I'm a PA at the University of Colorado Hepatology Clinic. I've been working in hepatology and with liver transplant patients for about 15 years now. And I see patients with a variety of liver diseases. The area of MASLD and MASH is one of particular passion and interest to me. So happy to be here helping with education on this topic today. You can use this QR code to register for this meeting. So today we're going to be talking about MASLD, which is metabolic dysfunction associated steatotic liver disease, and the category of MetALD, which is metabolic dysfunction and alcohol associated liver disease. We're going to be using a patient case to go through this. So our patient is Ashley. She's a 52-year-old woman who was referred after an ultrasound showed mild hepatomegaly and increased hepatic echogenicity consistent with hepatic steatosis. She feels well and has no complaints today. We do note that her body mass index is 29.4, so kind of right on the borderline of obesity. In terms of her past medical history, she has polycystic ovarian syndrome. We know PCOS is associated with insulin resistance, hypertension, as well as hyperlipidemia. She reports drinking on average 2 glasses of wine per day. On physical exam, her liver has a smooth liver edge, non-tender abdominal exam. She doesn't have any features of cirrhosis or portal hypertension, so no jaundice or ascites or spider angiomas, pulmonary erythema. Relatively unremarkable physical exam. And you note that she is on medications for hypertension, and she's also appropriately on a statin for her hyperlipidemia. She reports taking a multivitamin and milk thistle. And I always ask patients about herbal supplements. We're just seeing so many patients on herbal supplements these days, and we definitely see cases of liver injury and liver toxicity from herbals. So definitely something you want to ask about in your history. All right, so diving further into her case, in terms of her vitals, you can see that her blood pressure is mildly elevated, consistent with her history of hypertension. Again, her weight and height puts her at a body mass index of 29.4, so borderline obese. In terms of her labs, her transaminases are mildly elevated. I do note here that her AST is slightly higher than her ALT. It's not flipped in a 2-to-1 ratio like we would see necessarily with alcohol-related liver disease, but we tend to see the ALT run higher than the AST with MASLD and MASH. Not always, but that's kind of a pattern that we generally see. Her alkaline phosphatase is mildly elevated at 140, so you would want to consider when you do your full serologic workup on this patient to potentially check an AMA and rule out PBC. Her total bilirubin is 1.2, so kind of upper limit of normal. Her platelet count is 210,000, so still within normal range. Her hemoglobin A1C puts her in pre-diabetic range, and her triglycerides are mildly elevated. So we do a FibroScan on this patient, and her KPA comes back at 11.4, which puts her at about F3, so certainly significant advanced fibrosis by FibroScan, and her CAP score is 310, which correlates to severe steatosis. So we would consider this broad category of steatotic liver disease. We can break this down further into our patients who have MASLD, so who have evidence of hepatic steatosis with at least one cardiometabolic risk factor, and then patients with MASH or metabolic dysfunction associated steatohepatitis who have evidence of inflammation from the fatty infiltration in their liver, typically evidenced by elevated transaminases. You want to note that the definition of MASLD really excludes patients who, for women, consume more than 20 grams of alcohol per day, or for men, more than 30 grams of alcohol per day. And then there's this category of patients who have MASLD with increased alcohol intake. So this is going to be patients for women who are consuming more than 140 grams of alcohol per week, or for men, more than 210 grams per week. Or if you're looking at daily intake for women, more than 20 grams, or for men, more than 30 grams of alcohol per day, all the way up to an upper limit for women of 350 grams per week, for men, 420 grams per week, or daily alcohol intake of 50 grams for women and 60 grams a day for men. And note that within this category of MetALD, there is a spectrum from kind of more your MASLD predominant patients to more your ALD, or alcohol liver disease predominant patients, depending on what their actual amount of alcohol intake is per day or per week. And then if you have patients who don't necessarily have the cardiometabolic risk factors, but have excessive alcohol use, you can see steatotic liver disease. And these are going to be your patients who have alcohol-associated liver disease, or ALD. And then you need to consider patients who might have drug-induced liver injury. We can see steatosis, monogenic diseases like lysosomal acid lipase deficiency, LALD deficiency, hepatitis C virus, celiac disease, Wilson's disease, some other rare inborn errors in metabolism, and then the category of just cryptogenic steatotic liver disease. So when we talk about alcohol use with our patients, and this is something that when you're taking a history, if you're seeing liver patients, you need to ask about alcohol use, get comfortable asking about alcohol use. Patients don't always like to talk about it, and so you really do have to create this environment that is open and non-judgmental. And of course, patients aren't going to report their alcohol use to you in grams. So you really need to ask patients, tell me more about your drinking habits. Some patients may not drink every day. They might not drink on weeknights, but they might drink on the weekends. So you want to ask about their habits with drinking, kind of exactly what they're drinking, kind of get an idea of, pour sizes. And what this slide is showing is that you have all of these different types of alcohol here, obviously different volumes of alcohol. And all of these drinks represent one standard drink. In the United States, it's 14 grams. Of pure alcohol. There's slightly different values if you're looking at European standards, but all of these would count for one standard drink size. So when we have both risk factors for MASLD, which you can see here on the left, so insulin resistance, diabetes, obesity, visceral fat, unhealthy diet, sedentary lifestyle, genetic susceptibility, and you add alcohol intake with that, when these two things coexist, there are these pathogenic pathways in the liver that become sort of additive or synergistic in driving disease progression. And so basically what happens is you get this impaired lipid handling in the liver, which leads to more oxidative stress. You can get alterations in the intestinal microbiome. All of this leads to this inflammatory response in the liver, which can lead to accelerated fibrosis and disease progression when you have both MASLD plus the contribution of alcohol. So this graph is just showing basically on your x-axis, you have the drivers of steatotic liver disease. So alcohol use, different genes that are involved, your cardiometabolic risk factors. And on the y-axis, you have severity of liver disease as reflected by a fibrosis score based on FibroScan or VCTE. And what you can see here is, this is based on observational studies, is that patients that have even early MetALD or ALD have more than 3 times the risk of developing decompensated cirrhosis compared to patients who just have MASLD and MASH alone. So the contribution of significant alcohol use in this patient population really does confer a worse outcome. This is a really high-risk group. So this was a study that looked at over 180 patients with presumed MASLD and MASH, and their alcohol intake was assessed by ethyl glucuronide in hair and urine, and that was compared to kind of more conventionally used measures such as the Audit-C questionnaire, biomarkers like MCV, GGT, carbohydrate deficient transferrin, the ALD NAFLD index, And basically, what they found is that a substantial portion of these patients, about 25 to 29% with presumed MASLD, were actually at risk for alcohol-related liver damage with moderate to excessive alcohol use when they actually base this upon objective biomarkers. So it shows us that we can't rely just on patient reporting. Patients tend to underreport alcohol use. And so we really do need to use, in addition to these questionnaires like Audit C, we really need to use objective biomarkers in assessing for alcohol use and quantifying alcohol use. So when we're assessing MetALD, so over here on the left, you're going to first, assess for evidence of metabolic dysfunction with your typical cardiometabolic risk factors, BMI greater than 25, or you can use waist circumference, pre-diabetes, diabetes, an impaired fasting serum glucose above 100, hypertension or use of an antihypertensive drug, elevated triglycerides, or if they're on a lipid lowering medication. And you just want to pay attention, if a patient has isolated hypertension or hypertriglyceridemia, alcohol can actually cause or exacerbate hypertension and hypertriglyceridemia, and that should really trigger you to screen for alcohol use in those patients. And that's where you might want to consider using a PEth test. And then, of course, like we said, also in this patient population, assessing alcohol use. And you want to really try to quantify their alcohol use in grams per week based on, asking them about their drinking patterns, how much they're drinking on a daily or a weekly basis, and if they've ever had any prior consequences of their alcohol use, for example, a DUI. And then keep in mind the kind of limits here for alcohol use. Again, for MetALD, between 140 and 350 grams a week for women, or 210 to 420 grams per week in men, which corresponds to a PEth between about 25 to 200. That would have the patient fall in the category of MetALD. When you're looking at levels of alcohol intake that are greater than that criteria, then that's going to be more associated with alcohol-associated liver disease. And then, of course, you're going to want to always complete your full serologic workup to exclude other etiologies of steatotic liver disease. But we always want to assess for alcohol use in this patient population because, as we've seen, patients who drink alcohol with MASLD and MASH are at risk for progression of their liver disease. So we got a PEth on our patient, and it came back at 120, which correlates to kind of moderate to heavy alcohol consumption. Now, the PEth test, it is kind of analogous to a hemoglobin A1C for diabetes. So it really gives you an idea of alcohol use over the preceding 2 to 4 weeks. It's a phospholipid that's formed exclusively in cell membranes in the presence of alcohol. So it's really highly sensitive and specific as a direct biomarker for recent alcohol consumption. There's no significant variability by sex or by BMI. You can rarely see false positives if the patient has had recent blood transfusions where there was a lot of alcohol in the donor. So that's just something to be aware of. So this was a study of over 600 patients that were overweight or obese with greater than 1 cardiometabolic risk factors. And it was actually a study looking at the role of non-invasive testing to assess fibrosis in this patient population. About 15.7% of these patients were actually found to be at risk of MetALD. And almost 80% of those were identified by use of the PEth test, and only 21% by self-report of alcohol use. So again, we need to use these objective biomarkers and not just rely upon patient reporting, because we're going to miss some patients if we just rely on patient reporting. So again, going back to our patient and just looking at her risk factors. So she does have the cardiometabolic risk factors of hypertension and hyperlipidemia, which I mentioned earlier. Alcohol consumption is really directly intertwined with those. Excessive alcohol can both cause and exacerbate hypertension and hyperlipidemia. So there's been multiple randomized controlled trials and meta-analyses that show this bimodal kind of phasic effect of alcohol on blood pressure, where moderate to high doses of alcohol, initially you see a lowering of blood pressure up to 12 hours, followed by a delayed increase in blood pressure after 13 hours. And we know that chronic alcohol consumption, even at moderate levels, is associated with sustained increases in blood pressure and a higher risk of hypertension, especially if someone's drinking more than 3 drinks a day. We also know that decreasing alcohol use can result in a reduction in blood pressure. So this was a study that looked at the mean plasma triglyceride concentration over 10 hours after administration of 2 standard drinks or water. And what was kind of interesting is that acute moderate alcohol intake did not significantly increase the plasma triglyceride concentration in individuals who had baseline hypertriglyceridemia. They only had a 3% increase in triglycerides 6 hours after consuming alcohol, which wasn't really significantly different from their response to water alone. But in contrast to that, patients without baseline hypertriglyceridemia actually had a 53% increase in their triglyceride concentration after alcohol intake. So we know that alcohol acutely raises fasting triglyceride levels. We know that chronic alcohol use can cause elevated triglycerides. This effect is amplified with alcohol consumed with high-fat meals. And we know that for patients who have hypertriglyceridemia, excessive alcohol use on top of that can also raise their risk of developing pancreatitis. All right, so going back to our case then. So kind of looking back in aggregate here, Ashley has these cardiometabolic risk factors for MASLD and MASH. With an average of 2 glasses of wine per day per her report and a PEth test of about 120. So she really falls into the category of MASLD predominant MetALD. So what are the current treatments going to be for this patient? So at the foundation, always diet. I recommend a high protein, low carbohydrate, low sugar Mediterranean diet, really encouraging patients to try and reduce or minimize their consumption of the refined, ultra-processed carbohydrates and sugar in their diet. Exercise, ideally some combination of cardiovascular exercise and strength training with the ultimate goal of weight loss. We know that a 7 to 10% total body weight loss can really help reverse inflammation with MASH. Is she a candidate for Rezdiffra or resmetirom? So resmetirom is not recommended for patients who are drinking more than 20 grams a day of alcohol for women or greater than 30 grams a day of alcohol for men. So right now, she's not a candidate for resmetirom based on her current alcohol use. I would counsel her to quit drinking. We know that she falls into, based on her FibroScan, she has stage 3 fibrosis. So when patients have if stage 2 or above, certainly I recommend complete cessation of alcohol use because there are risks for progression of fibrosis. But we know there's not really a safe amount of alcohol that's been established for patients with MASLD and MASH. So I counsel these patients to quit drinking alcohol. But you could have her stop drinking and then reassess again with objective biomarkers like PEth over the next few months. And if she is able to reduce her drinking and remain sober, consider starting resmetirom at that time. You could also consider starting her on a GLP-1, and there are some studies showing that GLP-1s can help patients reduce or even stop drinking alcohol, as well as the benefits that we see from GLP-1s with MASH. So again, really counseling her to stop alcohol use and counsel her that continuing to drink alcohol is going to accelerate progression of her liver disease. She does need screening for HCC. So she has stage 3 fibrosis, and we know that in patients with MASH, even if they don't have cirrhosis, they are at higher risk of developing hepatocellular carcinoma. So she needs an ultrasound at minimum every 6 months. All right, so ideal MetALD definitions for clinical trials. So we definitely, as we've talked about here, we want to base this on objective biomarkers to overcome the underreporting of alcohol use by patients and kind of really standardize the assessment of, recent alcohol use, quantifying alcohol use, but also to certify alcohol abstinence. So really utilizing that PEth test is very, very useful. And then you want to ensure that the drivers of liver disease are present. If their cardiometabolic risk factors are just hypertriglyceridemia or just hypertension, you want to reassess over time if they quit drinking, if those cardiometabolic risk factors persist after they stop drinking alcohol, or potentially if they only have one cardiometabolic risk factor, kind of careful interpretation of that, or consider using more than one cardiometabolic risk factor, especially if it's just hypertension or hypertriglyceridemia. But really, these trials, ideally, we want to include patients who meet criteria for MetALD, because as we've talked about, these are the patients that are at even higher risk of progression of their liver disease and are at risk for worse outcomes. Okay, so take-home messages. So this new definition of MetALD, again, is alcohol intake beyond 140 to 350 grams of alcohol per week for women and 210 to 420 grams per week for men. Remember that, kind of traditionally used clinical criteria could actually underestimate the presence of MetALD and even ALD due to patient underreporting. So you really want to try and incorporate these objective biomarkers like the PEth test. You want to ensure that the drivers of liver disease are present over time. In particular, if you're using hyperlipidemia, hypertriglyceridemia, or hypertension, really consider that, do those metabolic risk factors persist after the patient quits drinking? And consider adequate exposure to those risk factors. And just remember that patients with MASH and MASLD who drink alcohol are at higher risk of progression to cirrhosis and decompensation and hepatocellular carcinoma. It's really a high risk group. And again, that clinical research ideally should facilitate an objective MetALD diagnosis so that we are studying these patients appropriately since they are at higher risk of progression. So you can visit this website for more disease state education. There's lots of great resources on the MASLD MASH community network, lots of really good educational videos. Are there any questions? And I'm always happy to answer questions if anyone wants to reach out to me on my MASLD community digital hub as well.